Welcome to Chapter 13, Vital Signs and Monitoring Devices. Emergency Care, 14th edition. So we're going to talk about gathering vital signs, all the things that go into vital signs. Okay, vital signs, these are major components of an assessment that will take a few minutes to complete. The vast majority of patients should have an assessment that includes vital signs measurements. Help indicate important conditions or trends in the patient condition that require particular treatments in the field or prompt transport to a hospital. And they're typically taken during the secondary assessment after the primary assessment to find and treat immediate life threats. So what are vital signs? They are outward signs of what is going on inside the body. They include pulse, respiration, skin color, temp, and condition, pupils, blood pressure, all those good things. Oxygen saturation is not a vital sign, but often included with consideration of vital signs. I'll argue that oxygen saturation is a vital sign as well, as is capnography. Those are all vital signs. Capnography is not something that we can take easily. You have to have a big monitor to do, but we'll talk about capno a little bit. Baseline vital signs, so these are the first vital signs obtained, and then any kind of repeat vital signs are then gathered for further information and to establish trends. A pulse. So pulse is a palpable pressure of the heart beating, causing the blood to move through the arteries in the waves. It can be felt by placing the fingertip over an artery where it lies close to the body's surface and crosses over a bone. The pulse is the pressure wave pushed out when the ventricle contracts and pushes blood into the body. That is what you're feeling. When we're taking a pulse, we want to consider two factors, so rate and quality. When we assess rate, we count for 30 seconds and multiply by 2. You can count for 15 seconds and multiply by 4. Just kind of depends on how you're going to get there. So the pulse rate is the number of beats per minute. Normal rate for an adult at rest is 60 to 100 beats per minute. Tachycardia is anything above 100, and bradycardia is anything below 60. Now, let's talk about this for a minute. So if you've got a patient who has a heart rate of 120, am I going to treat that as tachycardia? Yeah, I'm going to treat it as tachycardia, but I'm not necessarily going to do anything for it, okay? It's not anything that would warrant me to treat, unless there's something else going on, okay? Some patients have anxiety, and they have what we call white coat syndrome. So everything goes up when they see somebody who is in the medical field, nurses, paramedics, EMTs, doctors. I mean, it's just that anxiety. It just happens. Bradycardia, again, I'm not going to treat a patient who is at 50 if they don't have any other signs and symptoms. So bradycardia is at less than 60. Some patients who are athletes who work out, their heart rate can be in the 50s or 40s. Patients who are on medications, such as beta blockers, lower the heart rate. Their heart rate can be in the 40s and 50s. So it just kind of depends on what the patient's doing, how they're reacting, what medications they're on, and various things like that. So anything above 150 beats per minute or or above 120 beats per minute or below 50 across several measurements is considered a serious finding. During an emergency, Again, not unusual for the pulse rate to temporarily be between 100 to 140, especially if you were just in a car accident. Your heart rate's going. Remember that that sympathetic nervous system, it's amped up because, you know, in an accident we are preparing for that fight or flight. So that's what happens. Anything above 150 is considered supraventricular tachycardia, or SVT, and it is a significant finding. And it's got to be treated. And we'll talk about that in the cardiology chapter. Two factors that determine pulse quality. So rhythm, and this reflects regularity. So you can have regular, it's regular when the intervals between the beats are constant. So you've got a beat, 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 beat. Or it can be irregular. It could be beat, 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 beat. Irregular. Okay. You can also have irregularly irregular, where it's irregular and then on top of that it's even more irregular. Okay. Force. So when we talk about force, that is the pressure of the pulse wave as it expands in the artery. The pulse should feel strong. It should not feel thready. Thready is when the pulse feels weak and thin. So you can have thready, you can have bounding, and regular. Bounding is when the pulse is like super fast, or it feels like it's bouncing your fingers up and down. And bounding, if you like, to put it in as an example, if you go to exercise and you feel your heart rate you feel that heart rate, you don't have to necessarily touch it to feel it or anything like that, then that's that bounding feeling. Common pulse locations. So radials, we're going to use in patients 1 year and older. It is found by placing the first 3 fingers on the thumb side of the patient's wrist, just above the crease. Brachial pulse is used in patients who are 1 year old or younger, and it's in the upper arm. The carotid, so it's felt along the large carotid artery on either side of the neck. Obviously, you don't want to feel both carotids at the same time, and you don't want to put too much pressure on that carotid artery to feel it. Carotid is a central pulse. Your brachial and radial pulses are both peripheral pulses. So when we assess pulse, you want to count pulsations for 30 seconds and multiply by 2. And if the rate, rhythm, or force is not normal, continue with a count for a full 60 seconds. And then you're going to just kind of judge the rhythm and force based on what you have experience with. When you take a pulse, you're going to take like the first 2 fingers, place it on the radial area, and you're going to just apply pressure just enough to where you feel it. You don't have to push hard, because if you push hard, then it cuts it off. So you've got to kind of figure out where that pressure is to actually feel the pulse. Respirations. So with regard to vital signs, respirations are the act of breathing in and out. The measure includes both rate and quality. The number of, so rate is the number of breaths the patient takes in 1 minute. It can be classified as normal, rapid, or slow. A normal rate for an adult at rest is 12 to 20. And this is influenced by the age, sex, and physical size and conditioning of the patient. And it also includes the emotional state of the patient. If they've got anxiety, their respiratory rate is going to be high. Unusually fast or slow respiratory rates may require oxygen administration or providing ventilation to patients in respiratory failure. We talk about quality. There are 4 categories, so they can be normal, shallow, labored, or noisy. You can have more than just one of these, but you're going to check those. Rhythm. So if you observe irregular respirations in an unconscious patient, you should report and document it. You want to count the respirations after assessing the pulse rate and count the number of breaths taken over 30 seconds and multiply by 2. Again, you can do 15 seconds and multiply by 4. You want to note the rate, quality, and rhythm of respiration. Skin. Skin color, temp, and condition of the skin can provide valuable information regarding circulation. So cyanosis is what those fingers are. They've got blue tips, so that's cyanosis. Red flush skin is typically seen in the face, and it's up there. Mottling is down there at the bottom, and it basically looks like that. They're just little blood poolings. Capillary beds have opened up, and it's where the blood has accumulated. And then rashes up there in the upper right of the screen, and then pitting edema. So yeah, pitting edema, it can be a sign of various other things, but it is a skin sign. Best places to assess skin color in adults is the nail beds, the inside of the cheek, or the inside of the lower eyelids. In infants, it can be the palms of the hands and soles of the feet. And in dark skin patients, it can be lips and nail beds. Abnormal skin colors include pale, cyanosis, flushed, or jaundiced. Jaundiced is usually a yellow color, and typically in adults that means that they have some type of liver failure. Temperature, so we're going to feel the patient's skin with the back of the hand and note that if it feels normal, hot, cold, cool, or cold, and then condition as well, which is just dry or moist or wet. For children under 6 years, we're going to also evaluate cap refill. We're going to press on the nail bed or top of the hand or foot and release. And we're going to observe to see how long it takes for that normal pink color to return. Normal is less than 2 seconds. If anything other than 5 seconds, that means that your cap refill is not good. That means perfusion is not good as well. You can take this in adults. However, it's not a reliable sign for perfusion in the whole body. It is more of a sign of perfusion in that extremity. Pupils. So black center of the eye in a dim environment will dilate. In a bright environment, it will constrict. So essentially what you want to do in order to really take a pupil size, you want a dark environment that then you expose the patient's eyes to a bright light, like a pen light. So when we assess, we're going to look for size, equality, and reactivity. Normal size is anywhere from 2 to 4, 2 to 5, depending on what you read. So normal size is that. You're also going to look at equality. Are they equal? Okay, are the pupil size equal, or are they unequal? If they're unequal, typically that means that they've got some type of head injury or stroke. And do they react? Sometimes pupils don't react, and that's more for like dead people. So note the baseline size, cover one eye and shine a light into the other eye, and repeat with the other eye. Blood pressure. So blood pressure is the force of blood against the walls of the blood vessels. Systolic pressure created when the heart contracts and forces blood into the arteries. Diastolic pressure remaining in the arteries when the left ventricle relaxes and refills. Normal pressure is a systolic no greater than 120 and a diastolic no greater than 80. AHA has actually come out and said that we're seeing a trend of normal pressures of 130 systolic and 90 diastolic. Any kind of change can indicate something very significant to those numbers. Excuse me. We're going to measure with a sphygmomanometer and stethoscope. The cuff should cover 2/3 of the upper arm and below elbow to the shoulder. You're going to wrap the cuff around the patient's arm, place the lower edge of the cuff about 1 inch above the crease of the elbow, and place the center of the bladder over the brachial artery. Prepare the patient. Just tell them, hey, this is going to squeeze, may hurt. Position the cuff and stethoscope. Palpate the brachial artery first, and then position your stethoscope over that brachial artery. And then you're going to position the diaphragm of the stethoscope directly over the brachial pulse or medial anterior elbow. Okay. This particular cuff on this picture has arrows, and this is where your brachial artery, where the bladder goes over the brachial artery. You're going to inflate the cuff, listen and inflate until the gauge reads 60 millimeters higher, or 30 millimeters higher than the point the pulse sound disappears. So when you obtain your systolic pressure, you're going to listen for Korotkoff sounds, basically. So there are 5 different Korotkoff sounds. When you slowly release the air from the cuff, the first sound that you hear is the systolic, and then the last Korotkoff sound that you hear is the diastolic. There are 3 other Korotkoff sounds that you can hear. The first one in between there is that the sound will go away, and then the second one is when it can come back, and then that third one is when it goes away again. So you want to make sure that you listen for definite sounds when it goes away. Diastolic pressure. When you continue to deflate the cuff, the sound turns to a dull, muffled thuds. That's that third Korotkoff sound, or that fourth Korotkoff sound. And then the reading on the gauge is the diastolic pressure. Yes and no, you can use that, or you can use when the sound goes away altogether. And that's what I would suggest, is altogether. Blood pressure by palpation. So position the cuff and find the radial pulse. Inflate the cuff. Obtain and record the systolic pressure. And note the reading when the radial pulse returns. So basically what you're going to do is you're going to inflate. You're going to put the blood pressure cuff on like normal over the brachial part of the arm. You're going to inflate it. And then you're going to slowly deflate the cuff. And then once it deflates, and you hear sound, that is your systolic pressure, and it's going to be recorded as whatever it is over palp. So if you've got a blood pressure, typically these pressures are going to be lower because you can't hear necessarily where the with a stethoscope on a normal blood pressure. So this is going to be a lot lower blood pressure, or it could be a higher blood pressure, but typically it's going to be a lower blood pressure, and it's just going to be like 80 palp or 76 palp or something like that. On a pediatric note, blood pressures are difficult to obtain on infants and children younger than 3 years old. Manual blood pressures. You can take automatic blood pressures on these patients, They are more useful information about the condition of an infant comes from observing conditions such as sick appearance, respiratory distress, or unconsciousness. Using an automated blood pressure cuff, so you're just going to position the cuff, you're going to push a button, and then it's going to obtain the blood pressure without you actually having to listen for it. Temperature, so narrow range of temperature allows chemical reactions and other activities to take place inside the body. Core temperature reflects level of heat inside the trunk. Normal temperature depends on the time of day, activity level, age, and where it's measured. You'll get a lower blood pressure or a lower temperature if you take a temperature in the armpit versus in the mouth. The best way to take a blood temperature is in the rectum. And a rectal temperature is what we should be taking. But nobody really wants to stick anything up anybody's butt. So, it also depends on how hot it is inside somebody's house. So it really kind of depends on how hot that it is inside that patient's house. Because, I mean, they could have it up to like 100 degrees and inside the house and, you know, have a blood pressure really high. Monitoring devices, so O2 sat, this is also called SpO2, and this is the ratio of the amount of oxygen present in the blood to the amount that could be carried. And it's expressed as a percentage. So SpO2 measures the oxygenation of the blood. So it measures the amount of hemoglobin that is circulating in the blood. Hemoglobin is what carries the oxygen. Okay, so it actually, what it does is it measures the amount of hemoglobin in the body, and it does it by a light where it in between two things on the finger or ear or forehead. Just kind of depends on where you can get a pulse ox. So when to use a pulse ox, protocol should govern when to use a pulse ox if a service has one. It generally includes all patients complaining of respiratory problems or otherwise at risk for hypoxia. We put a pulse ox on every single patient because it's available. You can buy them on Amazon for about 12, 13 bucks. They're fairly cheap. You can go to Walmart and buy one. So we use a pulse ox on everybody. So when we interpret pulse ox readings, normal pulse ox is 96 to 100%. Mild hypoxia is anywhere from 91 to 95. Significant or moderate hypoxia is 86 to 90. And severe hypoxia is 85% or less. Now, just because I gave you these numbers does not mean we need to treat these numbers. Okay? You also want to treat your patient, not just the numbers on the pulse ox. Depending on the patient, you may not give oxygen. I mean, it just kind of depends. Now, obviously, if they're below 90%, I'm going to treat them. And I'm going to do what I can to bring their O2 level up. Okay? Accuracy of the reading. It can be affected. So shock or hypothermia. If they've got cold fingers, their blood is not circulating as well. And so the hemoglobin is not circulating as well. Doesn't mean that they're not getting the oxygen that they need. Just means that their hemoglobin isn't circulating. Carbon monoxide. Carbon monoxide can actually give you false readings of higher than they actually are. So carbon monoxide attaches to the hemoglobin, and the hemoglobin then carries that blood around, or that carbon monoxide out. So yeah, it can actually show higher than what that patient is actually doing. Excessive movement and nail polish. These two things are really kind of a mute point now because of the way pulse oxes are created. Darker nail polish can affect the reading, but typically it doesn't. Anemia, where they may not have as much blood on a normal basis circulating through the body just because of the disease. And then hypovolemia, where they also don't have enough blood, but that is caused by some type of shock to the body. Blood glucose meters. So this measures the quantity of glucose in the bloodstream. It can help identify some diabetic emergencies. These are fairly cheap as well. What is the cost of these things? The meter itself is typically free. The cost is what the strips itself. So you have to have permission from your medical direction or local protocol to perform a blood glucose monitoring using a blood glucose meter. The state of Missouri says that you guys can obtain and treat patients with a glucose meter. So you guys can do that. And yeah. Monitors must be calibrated and stored according to manufacturer's recommendations. You're going to prepare the device, test strip, and lancet. Cleanse the patient's finger with alcohol. Perform a finger stick with the lancet. Apply blood to the test strip and use the glucose meter to analyze the sample and provide a reading. Normal levels include usually at 70 to 100 or 60 to 100. Anything below 60, we're going to start treating. Anything above 100, I don't necessarily treat until it gets to a point where I needed to treat it. Now, diabetics can live in a range of anywhere from 200 to 400 on a normal basis. That's just where they are at. So it's always a good thing to ask the patient what was your what was your last glucose reading, and what is normal for you, because their normal could be in that 200 to 400 range. Capnography. So this measures the amount of carbon dioxide exhaled. We use end-tidal carbon dioxide or EtCO2. Normal levels are 35 to 45. And this kind of indirectly indicates how well the tissues are using oxygen and performing other physiological functions. So if you think about, let's think about this in a more simpler way. So SpO2 measures the oxygenation in the body, and capnography measures the ventilation, how well the patient is ventilating, moving that air in and out. There's a couple different methods that we use to obtain capnography. So if the patient is breathing spontaneously, we can use a nasal cannula with a little tab on it to measure capno, and then it gets plugged into the monitor. There's also a tube to plug into for oxygen. In the ventilated patient, a plastic collar fits between the bag valve mask and the bag valve and the mask, or the advanced airway. Typically, we put it on the advanced airway in between the bag valve mask and the advanced airway, not between the bag and the mask. So this is a normal capno waveform. Yeah. So here we have another normal capno waveform. So A to B is post-inspiration. This is dead space exhalation. This is when the patient has exhaled all their air. There's no air coming out. B is the start of, or that they are inhaling. Okay. B is the start of exhalation. So the higher it is, this is our exhalation phase. C to D is the continuation of the exhalation, and we want this square, okay? We don't want like a shark fin or lower or anything like that. D right here is the end tidal value. So this is the peak concentration. This is where you're going to get that number, that 35 to 45 number, okay? So 35, anything less than 35 equals hyperventilation. The patient is breathing fast, and it also includes hypocapnia, okay? Anything greater than 45 is hypoventilation. The patient is not breathing as fast as they should be. They may have agonal respirations or something like that. And they're hypercapnic, which means that they are holding in carbon dioxide. Uses for CAPNO. It's a steadily rising end tidal can help you anticipate when a patient may soon require assisted ventilations or advanced airway management. Overdoses, it's better to watch end tidal versus respiratory rate. The patient can have a respiratory rate of 24 and an end tidal of 60 versus a patient who has a respiratory rate of 8 and an end tidal of 35. You want to confirm, maintain, and assist intubation. CPR, maintaining perfusion, and then ROSC. Any kind of a sudden spike in end tidal can indicate a pulse return. Asthma, COPD, and CHF patients can show this shark fin appearance. This shark fin appearance is super ominous. I'm getting ready to probably intubate or have to bag my patient because there's some type of an obstruction in that airway.